test came back positive, we notified those individuals within 5 business days. It won't go forward. Oh, there you go. For measures, we looked at demographics, social and health information. We looked at RT-PCR RNA from the oropharyngeal samples. We looked at antibody assays from blood samples. For knowledge, we used a 14-item true-false questionnaire based on guidelines from the CDC. For attitude, we used a 10-item scale to assess the degree of ease or difficulty of engaging in pandemic appropriate behaviors. For example, avoiding crowds, hand washing, and masking. For fear, we used a 7-item scale to measure the level of agreement to fear statements that I will share in the next upcoming slides. We had a total of 152 survey respondents who also completed the blood and oral swabbing components. Of that number, 108 completed the entire set of 7 fear questions, our main outcome variable. In regard to our specimens that we collected, we found 2 samples that came back positive for current active infection, and 5 had antibodies, and the positive results actually came back from the 2nd collection date in December. In regards to demographics, we found that 70% of our survey respondents were female. Over half were between the ages of 57 and 84. When asked for their opinion of how well they speak English, 56% described it as not well. In regard to income, 3/4 reported an income of 40K or less. In regards to healthcare, the majority had health insurance, and finally, more than half were diagnosed with cancer. And now for our fear responses. Sampled here are 4 striking results. As you can see on the left, the top left bar graph reveals that approximately 80% of survey respondents agree or strongly agree with the statement that they are most afraid of COVID-19. The top right graph reveals that 78% either agree or strongly agree that thinking about COVID-19 makes them uncomfortable. The bottom left bar graph reveals that 67% agree or strongly agree that they are afraid of losing their life to COVID-19. And finally, the bottom right graph reveals that close to 60% either agree or strongly agree that news stories about COVID-19 make them anxious or nervous. Initially, we hypothesized that knowledge and attitude toward pandemic behaviors will result in reduced fear of COVID-19. However, our data suggest that knowledge reduces fear while attitude does not. In conclusion, our analysis revealed that there is a low infection prevalence among this population, our sample. There is high levels of fear. We found no association between attitude and fear, but there was a strong association between knowledge and fear. Our study had several limitations, but the most concerning was missing data. Due to how lengthy our survey was, it was almost 100 questions. And finally, our next steps include further analysis. We wanted to compare cancer versus non-cancer members. We want to look at the fear after vaccination and perhaps to compare scores, the fear scores before and after the winter surge. This project would not be possible without the ACF members leaving their homes during the surge and coming out and giving us samples. The volunteers from BACF, the Nasaudi Lab, Alan, Brianna, Isabella, Michaela, and most importantly, our sponsors, ICTS and Orange County Health, for making this project possible. Thank you.
Great. How about, I have one question.
Yes.
And then we'll get to Dr. Shin's portion of presentation. So if you could just briefly answer the question of if you could clarify what and how knowledge and attitude, how they were defined and measured. Just briefly clarify that for us.
So for knowledge, we took pretty much questions from the CDC about their knowledge on COVID-19, how to prevent COVID-19, how it spreads. And it was a true false questionnaire. If they got a question right, it was 1 point. If not, it was 0 points. And with attitudes, we asked them certain behavior statements that they would either find easy to comply with or hard. For example, following guidelines from the CDC, staying home, not sharing spaces, wearing a mask. Did they find it easy or difficult? And then for fear, that was listed.
Great, thank you so much for clarifying that, Val.
Thank you.
Val, I think if you unshare your screen, I'll be able to start mine.
Thank you.
Great. Okay, so I'm going to be talking about trends in COVID-19 related behavior and antibodies among UCI students during the period starting from January to May 2021. So this is definitely a work in progress. We're still in the process of analyzing the data and of finishing up the testing as well. So, so brief background, we know that there have been several high-profile outbreaks in universities across the US. And so that SARS-CoV-2 can transmit at a very high rate in university settings. And while most students are going to be at pretty low risk of getting severe disease, we've seen, from the earlier presentation by Heather that it's possible, even with mild disease, that that many of the students who are infected could have long-lasting sequelae. Also, there have been studies that show that transmission within the universities can spill over to the wider community and increase morbidity and mortality in the general population because of uncontrolled spread within university settings. So given all these, it's important to monitor university students, especially with respect to social contact patterns, as well as mask usage on campus, and also to try to keep track of the degree of immune protection in the university setting among students. So the objectives of this study was to describe trends in social contact and mask usage over time among UCI students. And we also wanted to compare the various antibody responses between students with natural immunity versus those who have been vaccinated, because this has been studied in a number of different populations, but not among young adults, college-age adults. Our eligibility criteria included UCI students at the time of study enrollment, living on or near campus, and having no plan to graduate or relocate before June 2020. We started out with a random selection of students living near campus by having access to a database of students from the registrar's office. And we also invited via email confirmed COVID-19 diagnosed students who were identified through the Student Health Services. However, these two methods were very slow in terms of meeting our enrollment targets. So we later expanded the enrollment to all nursing students and medical students. So we did an email blast to nursing and medical students with a recruitment flyer. Participants received $20 reimbursement per visit for up to 3 visits. So data collection occurred during January to May 2021. So we just completed the final round of data collection a couple of weeks ago. We used a REDCap for online questionnaire surveys, and blood samples were drawn at the Student Health Services. Laboratory testing was done at the Masaudi lab, and as with the prior presentations, we used ELISA for testing the presence of IgM and IgG. So these are antibodies against the two different sort of proteins in the SARS-CoV-2 structure. So you may know that the spike protein especially is the protein that's being targeted by the vaccines. So we enrolled a total of 119 participants, and of those, 100 made at least one visit, 90 made 2 visits. So these are full data collection at those visits, and 68 made 3 visits. 50% of our students were undergrads, and of these, about 20 or so were nursing students. And 20% were doctoral students, 20% were medical students, and 11% belong to other student types. 70% of our students identified as being female, and our age range was relatively narrow, with about half of our participants being in the age category of 20 to 24 years. And in terms of immune status, at the time of enrollment, about 1/3 of our participants had a prior COVID-19 diagnosis. 18% had received 1 vaccine, 27% received 2 vaccines, and then we had a handful of participants who had both the prior diagnosis as well as vaccination, and 17% had no known exposure to COVID-19 and also were not vaccinated at the time of enrollment. And of course, throughout the course of the study, these numbers changed because many of these participants who were not vaccinated ended up getting their vaccine shots. So this slide shows the relationship of social contact over time. And so what we can see here is, and so this is from January to April and May. Most of our participants had, not surprisingly, contact with family and roommates living in the same home, and a much lower level of contact with family not living in the same house, coworkers, and other relations. And this didn't really change over time. Overall, there was relatively low social contact with people outside of their home. This slide shows a similar story. So in terms of social contact, most of it occurred within the home. There was contact in some contact in schools and workplaces and so forth, but for the most part, they were relatively low, and no obvious trend over time in any of these social contact patterns. So this slide shows mask use in indoor settings when they're with people who are not a part of their household. So from January to May, we looked at the percent of time that they reported using masks in indoor settings. So this first color category is that they use it every time. Green is most of the time, some of the time, and never. And really, even though there are some differences across time, in the statistical testing, it shows that there's really not a significant trend over time in mask usage either. And so finally, this graph shows the antibody response by exposure status. So for participants who had natural infections, so these are antibody titers. So the higher the titer, the stronger the antibodies that are responding to the spike protein. And so those who had natural infection and those who had one vaccine had relatively similar levels of antibody response, whereas those who had 2 vaccines and those who were naturally infected and also had a vaccine had a significantly higher antibody response. one thing to note is that, especially among those participants who had natural infection, you see a lot of them really don't have a very strong antibody response that we detected, which suggests that it's possible that the natural immunity can, especially is prone to wane over time, which has been shown in some of the other studies. So in conclusion, we found no significant changes in contact patterns or mask usage during January to May. And we found that students with natural immunity through prior diagnosis had highly variable SARS-CoV-2 antibodies, and that high levels of antibodies were detected among those who had 2 vaccine doses and also those who had natural infection plus vaccine. And I think this all shows the importance of just monitoring the immune response among students over time, just to make sure that there is robust protection over time. We do have in plan T-cell assays to be done with the samples that we collected, especially among those who had low antibody titers. It'd be interesting to see whether, despite the low antibodies, whether they had robust T-cell protection. Lastly, I'd just like to acknowledge the student research assistants who were just invaluable and just worked hard on this study, and as well as our partners in the Masali Lab, Student Health Services, and of course, the study participants. And would also like to thank the funding agencies. Thank you, and happy to take any questions for this presentation, as well as if you have any questions for Val for her presentation, please feel free to put them on the chat or the Q&A box.
Great, thank you so much. Maybe Val and Sanghyuk, if you stop sharing, then can pin you so that you're both available to answer any questions that come up in the Q&A box right here. And then I wanted to ask, I was very interested in your box plot slide there, Sanghyuk. What do you think was accounts for the difference between the box plot of the people that had, yes, thank you, the vaccine ×2 versus the natural plus vaccine? What are your thoughts on the differences in that exposure there?
Yeah, so I think it suggests that there's more of a, and even though these don't seem like maybe huge differences, we're in a log scale, exponential scale. So I think it's actually quite a bit of a difference.
Right.
And so in fact, it's been shown that really, and this is with a lot of infectious diseases, that the immune system, once it starts being activated, it can be boosted by an additional exposure. And of course, we have booster shots for many other vaccines that we have as well. So this natural infection plus vaccine appears to be sort of a boosting phenomenon, where there is the immune system recognizes SARS-CoV-2 to a certain extent, but then when the vaccine introduces it to again, and then it just kind of has this very much stronger response. And I think so this graph actually is very consistent with what we're finding out now, that in fact the vaccines, especially once they're provided with double dose, does appear to provide a much stronger and robust protection than natural immunity.
That was going to be my next question. so it is what I'm seeing. You've just corroborated. Getting that second dose seems to be very important. Yeah, according to this data right here.
Absolutely. And I do see a question.
Yeah, let me ask you that. So it says, do you have analysis on, or do you plan to analyze the correlations between prior infection and vaccine status with mask use? Also, it did seem that there is a declining trend in mask use every time, which corresponds with my observation in the community. Could you comment on that?
Yeah, no, absolutely. I think that's a really important analysis to do to look at the correlation. It's a little bit tricky on our part because of the study design is such that we specifically targeted people who had prior diagnosis. So there's a lot of potential confounding on, for people who had prior infection and who were not. And so, there needs to be that's an analytical challenge, but I think it's an important question that we will definitely look into. I think so. Statistically, the p-value is high in terms of reduced in terms of trends in mask usage over time. But I would say that is very possibility. It's a strong possibility, and it kind of makes sense with what we're observing, that there is likely to be less and less usage of masks consistently over time. And in fact, not surprising at all, given, especially with the recent CDC guidelines or recommendations that have come out as well. So I suspect that trend will, if it's not a trend now, it will become a trend, and it will continue.
Thank you. Thank you so much, both of you, for your presentations. Really, really interesting work. And just to end this with a note that comes from a participant that says, excellent studies and mentoring with the nursing students. So thank you to Dr. Pinto and to Dr. Shin for such great mentorships of the students. And so with that, I would like to go ahead and introduce our next speaker, who is Dr. Dana Rose Garfin. She is an adjunct professor here at the School of Nursing, and she is going to be coming on hopefully right now to help talk about finding benefits in a collective tragedy, a national longitudinal study of the COVID-19 pandemic in the United States. Dr. Garfin?
Great, thank you. Okay, so I need to. Okay, can everyone see my screen and hear me?
Yes, we can. Thank you.
Yes.
Okay, great. Great. So many platitudes suggest that finding a silver lining during times of adversity can be beneficial for ameliorating the negative effects of exposure to difficult times. Leonard Cohen said, there's a crack in everything, and that's how the light gets through. P.G. Woodenhouse said, always look for the silver lining and try to find the sunny side of life. And Martin Luther King said, only in darkness can you see the stars. Well, as we all know and have experienced, the COVID-19 pandemic was the most widespread stressor in the modern times. Its reach was truly unique in scope, magnitude, and duration. And it shattered our assumptions of safety, stability, and the way that we think the world should be. Early studies on the mental health impacts of COVID-19 suggested that mental health problems such as anxiety, depression, and post-traumatic stress increased during the pandemic, but perhaps not as dramatically so as many may have anticipated. And indeed, consistent with prior research on disaster and other trauma, resilience, even during times of great adversity, is common and perhaps even normative. So to understand what makes people resilient, it may be helpful to understand how people cope during times of crises. Well, tragedies fundamentally and dramatically shift our perspective of the way that we think the world should be. And one way that many people cope is through cognitive processes that try to integrate this difficult time into their logical understanding of the world. Some of these coping attempts are coined mental gymnastics, and these are attempts to understand, explain, and find meaning during times of adversity. And they are commonly reported after a trauma or a loss. But there are mixed results on whether finding this meaning is beneficial. And indeed, these cognitive processes are often paradoxically associated with increased post-event psychological distress. So in other words, finding meaning in something very terrible happening, sometimes that can be associated with increased feelings of distress. And more specifically, prior research has found that searching for meaning was associated with increased distress after incest, the loss of a child or spouse, the September 11th terrorist attacks, and natural disasters, including hurricanes. But with all of these, there's been all of these studies I just mentioned, there's variability in the type of event assessed, the duration, as well as the quality of the sample. So many of us heard during the COVID-19 pandemic, reports were peppered with reports of people spending more time baking bread, gardening, taking long walks with their friends and family, and trying new recipes. And a lot of this was people's attempts to find meaning, joy, and the sunny side of this unprecedented collective trauma. And research during COVID-19 has proliferated. So there have been some preliminary studies about whether these attempts, these coping attempts, were effective at reducing psychological distress. Well, one study of 1,429 older adults found that if they reported using more technology, they reported more social connection with their friends, family, and neighbors. A convenient sample of 733 individuals from multiple countries found that avoidance as well as struggling to cope was associated with increased anxiety and depression. Although these coping techniques, none of the coping strategies and techniques that this particular study evaluated were associated with post-traumatic stress in either direction. And another convenient sample of 5,545 individuals found that following routines, engaging in hobbies, and reporting staying outdoors more was associated with lower depression. So following implicit threats to meaning, participants may report having, finding meaning may be associated with the pursuit of broad goals and increased self-regulation. And individuals may counter feelings of meaninglessness in response to an uncontrollable event, such as the loss of control, death, or trauma, with reaffirmation behaviors. So following these kind of implicit threats to meaning, some people may report finding greater meaning across other domains, such as greater self-esteem, certainty about the future, greater belonging, a greater sense of spirituality, or an increase in their religious beliefs. So these kind of reaffirmation efforts or these explanations can be thought of as attempts to regain meaning during times when meaning has been lost, or there can be senseless adversity. So engagement in health protective behaviors during COVID-19 definitely took a great deal of self-regulation. A lot of these behaviors, in the United States and elsewhere, took a lot of individuals in individual self-regulation. And individuals had to refrain from engaging in activities that before the pandemic brought them psychological, social, and economic benefits. And while certainly many of these behaviors, people engage in them to protect themselves, a lot of the messaging surrounding these behaviors related to protecting other people as well. So whether people engaged in these health protective behaviors, that could be one way to measure if cognitive coping strategies, such as finding meaning and so forth, were associated with increased self-regulation and pro-social behaviors. So to explore this, we had several research questions. What positive benefits did people report during the COVID-19 pandemic? We're finding positive benefits associated with reduced traumatic stress responses. And was finding positive benefits associated with increased pro-social behavior or self-regulation via social distancing. So my colleagues and I explored these issues using data from an ongoing longitudinal study. So this study utilized mental and physical health data that was collected prior to 2020. And then we assessed folks shortly after the World Health Organization declared the COVID-19 outbreak a pandemic. We fielded a survey to over 11,000 American Speaks panelists. And during our wave 1 fielding, we surveyed folks in 3 different cohorts. So that was during the early phase of the pandemic. And then we assessed folks again last fall, so the end of September and the beginning of October of 2020. So to explore this issue of traumatic stress, perceived benefits, and health protective behaviors, this is the hypothesized model. So the blue writing describes the covariates and the dependent variable that we assessed at wave 1. So within this model, we included covariates that were typically associated with experiencing post-traumatic stress as well as social distancing. So demographics, prior mental health, COVID-19 exposures, community exposures, secondary stressors that were associated with COVID-19, as well as media consumption. And then we assessed that at wave 2, close contact with people who had COVID-19 illness, personal COVID-19 illness, secondary stressors, financial impacts, media consumption, as well as pre-pandemic negative life events. So you can see there is an orange and a yellow line going from post-traumatic stress to perceived benefits and from perceived benefits to post-traumatic stress. And basically the reason for this is we weren't sure which direction this relationship was, right? So was it that people's post-traumatic stress was associated with them looking for benefits or finding meaning? Or was it that something about this process of searching for this explanation and searching for this meaning increased their post-traumatic stress? So that's what those lines are. And then we had their acute stress, which is their traumatic stress response at wave 1. We examined whether that was associated with increased reported perceived benefits as well as increased post-traumatic stress, and then whether those 3 factors in turn were associated with health protective behaviors at wave 2. So that's the hypothesized model that we examined. So this plot, the red dots are the mean, and then the sorry, the violin plots show the distribution. So you can look at the red dots to find the mean. And we found that people reported a greater sense of community. They reported more time for leisure activities. They recognized new strengths and coping skills. They reported reprioritizing relationships, readjusting life priorities, and more gratitude as a result of the COVID-19 pandemic. So what predicted these perceived benefits? Well, women reported more, Black and African Americans compared to whites, Hispanics and Latinos, those who reported more media exposure, people who knew more people with COVID-19, as well as those with more secondary stressors. And these were actually very similar to the factors that predicted increased post-traumatic stress. So secondary stressors, media exposure, financial stressors, pre-COVID mental health ailments, and so forth. These presents the predictors of health protective behaviors. So here similarly, we have a similar set of predictors: women, Black or African Americans, those with more secondary stressors, higher media exposure, and knowing more people with COVID-19. Okay, so what did we find? Well, we found that people who reported higher acute stress at wave 1 reported greater perceived benefits at wave 2. So if you were more distressed, you had a greater post-traumatic stress at wave 1, you were more likely to report finding more benefits at wave 2. You were also more likely to have more post-traumatic stress at wave 2. And this is consistent with prior research that finds that distress at wave 1 or earlier will predict distress subsequently. We also found when we tested the model that was actually finding more benefits that was associated with increased post-traumatic stress at the follow-up or at the wave 2. So if you found more benefits, you were that was associated with increased post-traumatic stress. And all of those factors were associated with increased health protective behaviors. And yeah. We also asked people via an open-ended question to tell us if they had experienced any other positive benefits. And one of my colleagues, our postdoc, Nicholas Jones, generated a word cloud of these responses. And as you can see, the most common thing that our participants reported was more time at home with family that they otherwise would not have had. All right, so what is the takeaway here? Well, many Americans reported finding positive benefits during the ongoing COVID-19 pandemic. Acute stress at wave 1 was associated with finding more benefits at wave 2, and this in turn was associated with increased post-traumatic stress. And while finding benefits was associated with higher traumatic stress responses, it was also associated with increased performance of health protective behaviors. So in sum, analyses revealed that finding positive benefits, although common, did not mitigate the psychological effect of COVID-19. And in fact, it was associated with increased post-traumatic stress in longitudinal analyses. So COVID-19 was a shared collective trauma and really showed us all our common humanity and the difficulties that we all face. While resilience was common, certain groups are more likely to, at risk for problems over time, and they are also more likely to report finding more benefits. So we can find silver linings in COVID-19 and likely other adversity, but this in no way minimizes or even necessarily eases the psychological suffering that's associated with this exposure. So what we can do is focus on the present moment, honor the pain and suffering associated with the adversity and loss we all experienced during COVID-19, and use that as motivation to contribute to an improved society moving forward, engaging in pro-social behaviors and continuing to strive toward mitigating the intensity of the resulting physical and mental health consequences of adversity such as COVID-19 for ourselves as well as those in our community. Okay, that's all.
Great. Thank you so much, Dr. Garfin. That was fantastic. And I want to commend you, of course, for the amazing work that you did, but also for quoting Leonard Cohen on your presentation.
Oh, wait, my acknowledgement slide. Wait, I definitely didn't do that by myself. Of course, I want to thank all our collaborators, my lab, and our funding, of course, NIH and National Science Foundation, and our survey research firm. But so thank you, everyone. We can leave it on in the nice picture, though. Or do we stop my share now, I guess? Okay.
Yeah, Dana, why don't we stop sharing bright so that you can be there. Thank you for a fantastic presentation. Really, really compelling. We have a couple questions. So one was, Dr. Garfin, great presentation. How would you explain how greater perceived benefits was associated with PTSD?
So yeah, that was really interesting. It's not inconsistent with what others have found in the literature. So it's a pretty consistent finding that things like post-traumatic growth are associated with post-traumatic stress. So basically, when something terrible happens, people want an explanation. Their world is falling apart. Why is it falling apart? So, you know, our minds want to understand, our minds want to make sense of unthinkable events. So really this searching is part of a cognitive coping process. Although, you know, it's often very difficult to find meaning in adversity. So a lot of times these attempts are ultimately unsuccessful. And this in turn likely leads to increased post-traumatic stress.
I'm still trying to wrap my head around it. It's fascinating. So while I'm thinking about it, how about there was another question that says, interesting presentation. In your experience, do you think that the COVID-19 pandemic may have a different long-term mental health effect on people, or is it similar or just like other traumas?
That's a great question. So I think both. So, like I spoke of in one of the earlier slides, resilience is very common. I mean, people are resilient. People get through all kinds of terrible things. We really have a great capacity for healing and surviving and thriving. At the same time, many of us experience great difficulties during times of trauma, stress, adversity. And there have been many longitudinal studies, Alison Holman and Roxy Silver, they followed folks for years after 9/11. And, they found that in a substantial minority of individuals, that suffering can persist for years, even decades following. So I think that there is a lot of individual variability in how people cope and adapt to traumatic events like COVID-19. So I think we'll expect a lot of people will kind of have these learning, growing experiences. And I think we can expect that a substantial minority, might continue to experience negative health, physical and mental health consequences for quite some time.
Sanghyuk, do you mind if I ask one quick follow-up question to that?
Of course, please do.
So again, as I'm trying to wrap my head around this, is this something where you've mentioned resilience and growth, that we're seeking that and that we're actively pursuing that? And is it that attunement to what is happening that might somehow be a mechanism for the greater PTSD? Kind of allowing the trauma.
Yeah. So I think there, and this isn't really, this talk isn't really about toxic positivity, but I think some of it has that element of it, right? So there, especially in, American society, maybe modern society in general, there's this movement towards everything needing to be okay, right? Like if you're sad, you need to feel better. If you're depressed, you need to cheer up. Right. And it's like, sometimes there's things that are happening that there is no reason under the sun that we should be happy during them. Right. Like you lost your job, you got divorced, someone died. I mean, those are like very difficult things. And the normative response would be distress, so I think that sometimes that trying to kind of get around that experience, that's really a common experience that we all share as humans, is being, of course, our joys and our happiness, but also our suffering, and our times of loneliness and despair and loss. And, that's as much as part of the human experience as anything else. So I think sometimes trying to mitigate that and kind of sweep that under the rug, and, can paradoxically allow for more suffering to arise, rather than, kind of just sitting with that, acknowledging it, and knowing that we do have the capacity for resilience, and things will get better over time.
Thank you.
Thank you. So I do want to, again, thank you for that presentation. It's just, there's so many things to think about. I think one of the things that, some people have mentioned is that really here in the US, there were at least 2 pandemics. So, some groups experienced a very different kind of a pandemic than other groups, right? Mm-hmm. You have family members that are affected. You have, yourself and others who, lost loved ones, and then others who are relatively untouched. So, and I know that sort of personal experience variable is included in your model, which I think is great. But I wonder what your thoughts are about perhaps the dynamics of some of the variables in your model might be different in, a community in a population of people who experienced a certain type of a pandemic versus another. So perhaps something like a moderator analysis. Is that something that you've thought about?
So what would be the moderator? The moderator would be your experience. So if people had experienced greater personal exposure, and more benefits, or like so the moderator would be experience and distress predicting health protective behaviors?
The moderator would be personal experience of the COVID-19 effects, which again you included in your model. And in terms of how the sort of the positive framing and attitude and how that's related with your dependent variable, I just wonder if the dynamics might be very different. I'm not sure which direction it would be. I have hypotheses, but it just seems that honestly, it seems that some people have experienced a very different type of a situation than others.
Yeah, I think that point's very well taken. And, we haven't submitted the paper yet. So that's definitely something, that point's very well taken. We should definitely check that before we finalize the manuscript. And I will do so. I mean, my suspicion is that, and kind of from those descriptive statistics that I presented, I didn't really go into them in detail because for the sake of time, but they were pretty consistent. So it was the people who I would say, as you said, experienced the worst pandemic. So people who were lower in income, who were underrepresented minorities, who experienced more stressors. Those were the people who, rightfully so, reported more post-traumatic stress. They were also the people that had more of this cognitive process of trying to find a benefit or trying to find meaning. So if anything, I think that, perhaps that would be amplified in those populations who had a more severe pandemic and greater exposure to the pandemic. I would expect that those folks likely had greater post-traumatic stress as well as greater reports of finding benefits. So I would say maybe there's probably an amplification effect. That would be my hypothesis, but we can certainly check that before we upload the final version for review.
So I'll have to end the study design portion of this talk, and say thank you.
I can chat later about the analyses.
Thank you so much for this very stimulating talk and for all the presenters that have come so far. We're going to go ahead and take a 10-minute break. So people can do a bio break, etc. We will be back at 3:20. So if people want to mute themselves and turn their cameras off and then return themselves on at 3:20, we'll hear from Dr. Candace Burton on her work. So thank you again, Dana, and we'll see everybody in 10 minutes.
Can you see me?
There you are.
Yeah, okay. You texted me, turn on your video, and I was like, I'm right here.
Okay, beautiful background. It is 3:20, so I think we're going to go ahead and get going again so that we stay on track. Let me go ahead and move this here. So without further ado, I would really it's a pleasure to introduce our assistant soon-to-be Associate Professor Candace Burton. And she is going to be talking to us. She's here from our School of Nursing, and she'll be talking to us about the willingness to get the COVID-19 vaccine with and without emergency use authorization. Dr. Burton, looking forward to your talk.
Let me get my slides up here. Okay, now this is where it gets interesting because I'm going to try to put it into slideshow, and my screens always go blank for a second when I do this. And I'm like, oh no, where is everybody? Okay, here we go. Excellent. Can you see the slides? Somebody give me a thumbs up.
Yes. Yes.
Oh, great. Thank you very much. So thank you for having me. This is an oddly dated paper since it's only a few months old. This was the result of some work I did with my amazing team from public health back in Virginia. And we looked at the willingness to get the vaccine. This was before we had a vaccine, with and without the EUA, because we didn't know what was going to be coming and we didn't know when it was going to be coming. So we were really interested in, were people going to get it? Did people think about it? What might be the barriers to getting the vaccine? So we did some work on this. This is just sort of the place we were at the time that we wrote this paper. So as of November 6th, we had well over 48 million cases, or 48 million cases with just over 1 million total deaths already from COVID-19. We didn't have really effective, clear treatment regimens. The vaccines were in development. We didn't know how long that development was going to take, and we didn't know how long the approval process might be. So the potential for an emergency use authorization, an EUA, had been posited, and we were wondering what happens in the context of an EUA. Does that make people more likely, less likely? Will they have different concerns about getting the vaccine? So what we did, get the slides to advance. There we go. What we did is we used a professionally selected survey panel through the Qualtrics organization. We ended up with 788 adults within the United States, and we had them draw from their panel to give us a reasonably diverse sample so that we had some idea that this might be generalizable. So we had about half men and half women, and then about a third divided by race: Caucasian, Black, Hispanic, Latinx. Our theoretical frameworks were the application of the health belief model and the theory of planned behavior. And we were sort of looking at these constructs of, is there a stronger perception of vaccine benefit than risk for COVID? So we wanted to know if people felt like it was more risky to not have a vaccine or to get the vaccine. And we wanted to know how the barriers to determining whether to get the vaccine, or if they thought they could get the vaccine, were affecting their plans. And then with the theory of planned behavior, we wanted to understand people's attitudes, what their social groups seem to think, and their intentions toward getting a vaccine. So these are all kind of amorphous variables, and we did structure our questions around the constructs from each of the theoretical models. But really, what we were trying, oh, there's a terrible typo, I'm sorry about that. We were trying to get at sort of the social determinants and the community-based influences on whether or not people were going to get the vaccine. So we wanted to understand who thought their risk for COVID was worse than the risk of something happening to them as a result of the vaccine. We wanted to understand who thought they could get the vaccine, who thought they couldn't, who might be willing to get the vaccine and who wouldn't, and why. So that's kind of where we're going with this. So these are our results. I'm going to attempt to move some of these windows so that I can see the slides at the same time here. So what we ended up with was we had a mean age of about 46 years old within our sample. 88% of the sample had health insurance. Along political lines, because this was election season, we ended up with roughly half Democrats, 21% Republican, and 30% that identified as independent. 20% of the sample identified themselves as being very religious, and the rest of the sample shook out, as you might imagine, along a normal distribution, with the bulk of folks falling somewhere in the relatively religious to not very religious, and then of course the tail end of not at all religious. In terms of intentions to get a vaccine, we found that 31% of the sample said they were planning, definitely planning to get a vaccine, but almost 12% were definitely planning not to get the vaccine, with or without the emergency use authorization. We did see that higher education levels predicted willingness to get the vaccine under an emergency use authorization. And we also found that Latinx and white respondents were more likely than Black respondents to say that they were willing to get the vaccine under the EUA. So then we wanted to kind of know, all right, what is predicting these outcomes? How has this sort of shaken out, and why? So we found that, and again, these are going back to the constructs inherent in the two theoretical models that we were applying here. The first of the predictors that we identified was positive attitudes toward vaccination in general. So people who believed in the efficacy of vaccines for other conditions were also more likely to be planning to get the COVID vaccine. Social norms supporting vaccination. This is kind of a broad descriptor, but what it is referring to is that for people who reported that they had friends and family who endorsed vaccination, it was sort of a positive peer pressure effect that they felt they would be more likely to get the vaccine as well. Then we came to self-efficacy. That might seem like an odd thing to measure here, but we were interested in knowing whether people thought they could get it. If they believed that they would have access to it, if they believed that it would be easy for them to get the vaccine, and whether or not that predicted their willingness to plan to get it. So, of course, self-efficacy definitely was a positive predictor of vaccine planning, and then the perception of susceptibility to COVID-19. So, again, relatively logical progression here, insofar as the perception of being susceptible to COVID-19 and perceiving one's risk as higher for illness and potential mortality increased people's willingness to get to have the intention to get the vaccine. Oops. There we go. So then we wanted to look at the potential barriers to get the vaccine. And these were the things that people cited as reasons they would not be willing to get the vaccine or did not plan to get the vaccine. I thought it was interesting that we found that feeling like it would be too much trouble to get a vaccine. I would love to elaborate on what that means for you, but unfortunately I cannot, because that's the way we couched it on the survey. The question was about whether or not somebody believed that it would be easy to get a vaccine or that it would be too hard for them to get it. So the idea that it would just be too much trouble, and that might have to do with transportation, it might have to do with getting access, it might have to do with other kinds of resources. Fear of needles, which was kind of a disappointing thing to find out that people would rather risk death than get a shot. And obviously, now that we've been giving the vaccines for quite some time, ironically, probably everyone here knows that the needle is really tiny and you barely even feel it when you do get the vaccine. Another barrier was concern about side effects. And that makes a lot of sense when you think about how fast this was all happening. When we wrote this paper, it was very early on in the pandemic in terms of it having really exploded. And so we weren't at the point of really understanding how the vaccine supply chain was going to shake out. And we didn't know how quickly it was really going to come together. So people were worrying that there would be side effects because it hadn't been vetted properly or it hadn't been tested effectively or whatever. So there were concerns about side effects. Some people were anticipating shortages of vaccine, that there wouldn't be enough. And so they were anticipating that being a barrier to them getting the vaccine. And finally, just that, again, the concern about the rapid development cycle of how quickly the vaccine was put together. So that was kind of interesting. And I do think, you know, to go back to this slide and look at the demographics a little bit, given what was going on in the country at the time, socially and politically, it's not all that surprising that people were feeling an absence of information about what was happening, how fast it was going to happen, what the development pipeline might look like. I think there was a lot of confusion about what was believed about the vaccine, what was believed about the pandemic, what various authorities were saying about it. So I think that kind of division within the sample reflects exactly what we have here in our results. So overall, 60% of our sample was willing or likely to get the vaccine, 25% specifically if the EUA applied. So let me break that down a little bit. So generally, 60% of people said they would probably get the vaccine without considering the EUA. So those people were thinking, so that 60% would apply to people who would be anticipating the full FDA approval process for the vaccine. If the EUA applied, which obviously it did, 25% of those people were still willing to get the vaccine. So 25% of the sample was still willing to get the vaccine, even if it had not gone through the typical full-length FDA approval process. We did really see an impact of structural racism on willingness. Black individuals in our sample were less likely across the board to say that they were willing to get the vaccine. So that was very interesting. And that has played out, I think, in what we've seen in terms of who is able to get vaccinated and who is not, and who has been showing up for vaccination and who has not. There is still obviously across the board vaccine hesitancy among several vulnerable populations, but it's interesting to have thought that certain groups would be less willing to get the vaccine, and then to find out that, in fact, what I've been hearing is that the Latinx population has been a little more reluctant to get the vaccine even now, but that also could be a function of where we live. But that actually it's the people identifying themselves as Black who were less likely to be willing to get the vaccine. So it's sort of interesting in terms of what's actually played out, because a lot of the news coverage that we've seen with thinking about vaccine hesitancy and who's getting the vaccine and who isn't has really played up the idea that Latinx populations are not getting the vaccine, whereas high Black residency populations are just not having access. So it's interesting to consider both of those things in terms of what's actually happened. Increasing age made people less likely to be willing to get the vaccine, EUA or no EUA, you know, and there could be a million reasons for that. I know that with my parents, for example, they were very much interested in getting the vaccine, but they had some older neighbors who were worried about what it would do to them and were suspicious of the process. So there were definitely some social factors in that as well. Our results were consistent with our health behavior change theory. The theory of planned behavior predicts positive attitudes and stronger subjective norms. Favoring vaccine would result in stronger intent to get vaccinated, and the health behavior model predicted that those who felt susceptible, who perceived themselves as being at risk from COVID, believed that benefits outweigh the barriers and have the self-efficacy to overcome any barriers, were going to be more likely to be vaccinated. So we were not super surprised, you know, but it's nice to have the validation in terms of, okay, what we have theorized is actually working in this particular population. I'm just going to check the time really quick. Oh, we're good. And then finally, there was, as everybody remembers, I'm sure, quite a lot of political stuff going on last fall with the presidential election coming up, and the sort of confusing messages that were coming out from the then administration and different aspects of different agencies. So there was some confusion about, okay, what is really going on? Is this, you know, as bad as we think it is, or is it just going to go away like a cold or the flu? And so I think there was also some uncertainty there that resulted just from the public side of things, the messaging that was coming out from the administrative political system. So that's about it in terms of the study itself. So I think we have a few minutes. I'm happy to answer questions if there are any.
Yes. Oh, go ahead. Go ahead. I was just going to say, maybe stop sharing your screen so we could see you in the panel.
Okay. I have multiple screens going on here, so I have to find where the share button actually went.
There you are.
There we go.
Thank you so much for that fantastic presentation, Dr. Burton. I do want to remind the audience to please go ahead and put your questions in the Q&A box to the bottom right. But I will go ahead and start out with a question. And I think you've been very comprehensive throughout your presentation. All the questions that I had while you were presenting, basically check. You've addressed all of them. But I wonder if maybe we can kind of dig a little deeper into, and this might just be kind of speculation, but I found it interesting with the finding that I think it was something like the respondents didn't want to deal with the hassle, or that it would be too troublesome to get the vaccine. And I wonder if it also is in line with some of the experiences that, especially people who are minoritized and people who are coming from, kind of discriminated backgrounds, where their interaction with the system, especially if they're underinsured or not insured, where things have been so painful in the past, like you had to spend all day to get something done, and the kind of the bureaucracy that you have to go through in the current health system. And I wonder if you can kind of comment on whether that might be kind of playing a factor here.
I wouldn't be surprised at all. Although we had a high rate of medically insured folks in the sample, they were not all medically insured, which is telling, given that it is, a higher education level sample overall, because these are folks who participate on a professional survey panel. So most of the people who sign up for panels like that have at least some advanced education. So we were kind of surprised that the insured rate was not higher. And so I do think that's a very astute point, Dr. Shin, about the possibility that having interacted with a system wherein your insurance is difficult to use, you can't get in to see a provider, it's hard to navigate, may have influenced some people's thinking about whether or not they would want to be bothered with getting a vaccine. And having worked in our vaccine clinic, I can tell you that people repeatedly told me how surprised they were at how easy it was for them to get in and get their vaccine. So I do think that idea of having to navigate this complex and difficult system probably did play a role.
If only all our healthcare services can be provided in that manner.
I know, right?
and with our fantastic students.
Yes, that too.
We have a couple of questions from the attendees. So here is the first one. Given the abundance of misinformation regarding the COVID-19 vaccines, what are your thoughts about the things that we can do as nurses, individually and as professionals?
That's a great question. I think, it's interesting because I am a co-investigator on the All of Us study, and a lot of the physicians on that team have been talking about the conversations they're having with their patients. And it's really surprising to me how many of them are reporting these really difficult conversations with patients who just don't want to do it, and trying to help them understand why it would be a really good idea for them to do it. And so I think one of the strongest things that we can do as nurses is to make sure that we're just communicating the correct information, given the amount of misinformation that's out there, and the fact that it did come together so quickly, so fast, almost you couldn't believe it. I think people have questions about, well, is this really safe? Does this really work? And then there are always the oddball articles that come out that tell you, 5 people out of 200 million got purple spots or something, and everybody thinks they're going to get purple spots. There was some dreadful article about people thinking that it was going to cause infertility because there were a few women who had altered menstrual cycles after the vaccine. And the first person they quoted in the article was actually a butcher. And he was saying he wasn't going to get the vaccine because he didn't want to endanger his female customers. So that was a little odd. And so I think being very plain spoken and having our own arsenal of correct information and knowing, what's out there, keeping an eye on the news, knowing whatever the latest sky falling headline has said is, and being able to talk, in a health literate way to friends, family members, patients, keeping that message out there, making sure that we are advocating for access within our own clinical environments. So if we know that, we have older patients who don't drive anymore, finding ways to make sure that they can get in to the clinic to get their vaccines, or if they're not able to navigate the MyChart portal, for example, the electronic health record with UCI, those kinds of things. I think, having those strong, correct responses to some of those questions and being willing to really discuss it. I mean, I think as healthcare providers, we get very frustrated with what we see as non-scientific beliefs about things. And so being willing to say, okay, I will hear you out. I will hear you out, and then, continue to navigate, okay, well, actually here, let me show you, this data or this article where this is actually explained, and let me explain a little bit about how this process works. So I think being open and having access to the right information and continuing to spread the right information are the best things that we can do right now.
Great, thank you. Sanghyuk, did you want to take the next?
Sure. So our next question is from Dean Nyamathi. She says, excellent question, Dr. Burton. Can you speak more about your thoughts about the political climate and its impact on willingness to get the vaccine? So maybe a little more detail.
Oh, I was trying so hard not to get into the politics.
Well, it's important. I mean, it clearly had a huge impact.
Yeah, I think it did. And the team that worked on this paper, we also do health communications research together and spend a lot of time looking at social media to kind of track where things are moving and what people are saying and thinking out in the larger world. And so I think, as back to the question that we were just talking about, there was a lot of misinformation and disinformation, frankly. There was a sense that if the president wasn't panicking, it must not be so bad. And I think, what happened on January 6th with the attack on the Capitol, I think we really saw how devoted the supporters of Trump really were. And so had he taken stronger action, had he taken a stronger stand, perhaps people would have understood the urgency a little bit more at the time, rather than believing, oh, well, he says it's okay, so it's going to be okay. So perhaps if he had displayed more of a sense of urgency, been more willing to take a stand about the need for a vaccine, the dangers of a pandemic, maybe we would have had a different kind of profile for folks. So those are my main thoughts on that.
Also, just want to point out that President Trump did try to rush the EUA process to have it go through before the election, presumably, so that he can benefit politically. So that's clearly not a very good message that for political reasons, we're trying to rush the process of authorization. So final question here. From Eleanor Weinstein, and on your study of self-efficacy, did you assess internal, external locus of control as a determinant of attitudes towards getting vaccinated against COVID-19?
We did not do anything that elaborate at all. We asked, and I've got, like I said, I have too many screens here. Hang on one second. Let's see if I can get to the document. I can tell you perhaps exactly what question we asked. We kept this fairly simple. It was a rather long instrument, or a survey rather. And so let's see if I have the actual questions here.
And just so you know, we're almost out of time.
Yes, okay. So I won't take up too much time, but we were interested in mostly what people thought of their ability to circumnavigate the barriers. So it was more along the lines of, do you think, that you can get to a place to get the vaccine? Do you think? So we didn't necessarily have the variety of dimensions that you're asking about. We were looking more at how certain are you that you could get a vaccine? How certain are you that you would be able to get to a place to get a vaccine? So we didn't go into quite the depth of dimension that you're asking about there. Unfortunately, we just didn't have the ability. Qualtrics is pretty strict about how many questions you can put on the surveys that they send out to their folks. So we had to be a little bit thoughtful about what we could and couldn't ask.
Thank you so much, Dr. Burton, for this fantastic talk. Really appreciate it.
Yes, my pleasure.
Some great questions. We're going to go ahead and move on to the next panel right now. So what I would like to do is introduce that person, who is Professor Alison Holman here in the School of Nursing. And she is going to come on board to share her talk, which is called Coping with COVID-19 and Cascading Collective Crises: Findings from a Nationally Representative Study. Hello, Alison. Looking forward to your talk.
Thank you. Can you hear me?
Yes.
Okay, so now I need to do this. Okay, are we good? I think we're good.
Yes.
Okay, so thank you everybody for giving me the opportunity to share with you my findings from our study on COVID that's been going on for the past year. So as we all know, the past year has been affected with a major stressor, which is called COVID, including that led to many financial stressors for people, that led to, we also had at the same time, the cascading effect of all of the climate change type wildfires in California and in the West in general. And we also had major social challenges in terms of police brutality and issues around racial discrimination and institutionalized racism that had the largest demonstrations in American history, people hitting the streets about racism in American policing. And so the year of 2020 was a year of cascading collective traumas. And the upshot of our work is to look at what are some of the mental health and physical health consequences of these kinds of effects. And so we did that. And we're very concerned that the exposures, both through direct exposure to the pandemic related issues and the stressors that followed, that trailed along from the pandemic, as well as the media exposure, may help compound the stress that people are experiencing. So what makes COVID a unique experience that might cause collective stress? Well, it's an invisible threat. We didn't know who was infected. We still don't know who's infected. We're getting vaccinated, so that's a good thing, but we still don't know who's infected. It's an ambiguous threat. We didn't know how bad it was going to get. It was a threat that created a very uncertain future. Our lives changed dramatically, and we didn't know what the future was going to look like. In fact, not only were we not sure how the future was going to play out, but we also had major challenges to our perceptions of time, which I'm not going to talk about today, but that's also another very significant contributor to mental health challenges associated with the pandemic. And then finally, the pandemic was a global threat. There really wasn't anywhere that was truly safe unless you owned a bunker, underground bunker in New Zealand, which is a few people do, very few people do, the wealthiest people. So the COVID pandemic was also unique in that It created the need for us to socially distance from people we love at a time when our natural instincts are to connect with family and friends. And that's something that we tend to rely on our family and friends for support during major stressors. But at this time, all of that was changed, and we had to connect with people in a very different way, if we could connect at all. It also created a challenge to us because it took away our typical sources of distraction. We might have wanted to go out or do something to get our minds off of the stress. Well, we couldn't do that because we weren't, the gyms, the bars, the restaurants, the movies were closed down. So we couldn't do some of the things that we usually do, people often do, to engage in sort of distracting themselves from some of their stressors. And this disruption affected pretty much all aspects of our lives. It affected our work life, it affected our social life, it affected our worship life. So the case of COVID was a pretty intense case. So, and as some of you may know, I do a lot of work that looks at the issue of how the media and the media exposure may impact people's mental and physical health. And so we were very, very concerned as the pandemic was beginning that the media was going to again do something like this, that the impact of the media might have a very negative impact on American health. So we decided to launch a study and to look at the public health consequences of COVID-19. Now, why do I bring up the issue of the media? Media is a double-edged sword. On the one hand, we look to the media during periods of high ambiguity and uncertainty because that's where we get information. We hope to get trusted information there. We seek risk assessments. We seek recommendations for self-care. We also go to the media because there's critical guidance that we can get. For example, in the aftermath of hurricanes, we go to the media to tell us where we can go for how to find a safe shelter, or we can go to the media to get advisories on where you are safe and where you're not. So the media is a really important source of trusted information. On the other hand, the media is full of rumors and misinformation, especially social media. Because it's not typically vetted for accuracy. So it's really important to understand the impact that social media and unvetted information that gets thrown around in the media can have on people. And perceptions, unfortunately, the perceptions of risk and anxiety that people experience goes up when people are ineffectively communicated with. That means if you don't share risk information in a clear, consistent way, you are running the risk of increasing the anxiety that the public has about whatever the source of the risk is. And then in our studies over the course of several collective traumas, our team has shown that overexposure to the media can amplify stress responses with downstream mental and physical health consequences. So in response to the COVID, the national emergency declaration of a national emergency around COVID-19, my colleagues and I began a study on COVID. We started our study using the AmeriSpeak panel, which is from NORC, which is from the University of Chicago. This is a probability-based representative sample of Americans for whom the mental and physical health was collected when they were recruited onto the panel. So this group of individuals, we have pre-pandemic health information on them. So it wasn't retrospectively collected, it was actually collected before the pandemic. Then we had the declaration of the emergency on March 13th. And then we had our study started on March 15th. So here, or March 18th, sorry. What we did, we took 11,000 members of the AmeriSpeak panel. Again, this is a probability-based representative sample of Americans, and we randomly assigned them to 3 cohorts. The reason we did the 3 cohorts was because we wanted to look at how do these symptoms shift in the beginning of the pandemic as the pandemic is worsening. So we had 190 deaths at the time of the first cohort completing the survey. We had 3,500 deaths in America at the time that the second cohort had finished the survey or completed the survey. And then by the time the third cohort completed the survey, 18,000 Americans had already died. So we wanted to see, how does this shift in the seriousness of the pandemic that we anticipated a shift, how did that shift, what impact did that have on mental health? And then in September, late September, early October, we went back into the panel. We took all of the people who were still available, and we got 88%, I believe it was, of our original sample completed the second wave of data. So now what I'm going to share with you is some of our data from these two surveys. In our first study, which we published back in the fall, what we looked at was, we looked at mental health. We looked at what did the mental health look like across those three cohorts in that early phase of the pandemic. And what we saw was exactly what we had anticipated, which is that over the three cohorts, as the pandemic progressed, those three different cohorts of people reported a higher and higher levels of symptoms, acute stress symptoms, as well as depression symptoms over those first three cohorts. What we then looked at were some of the predictors of these symptoms. What were the predictors of acute stress and depression symptoms during this time? Well, more exposure to the media coverage was one of the largest predictors. And importantly, and this is something we hadn't done in our previous studies, but we did here, we looked at whether exposure to more conflicting or confusing information in the media was related to people's mental health responses, because what we saw during that time was that people, on the one hand, were being told one thing, that, oh, we don't need to, we need to socially distance. And then there was the message coming out that, oh no, we need to open everything up. We need to, think people need to stay home. No, we have to open up and go to church. So there were very different messages being conveyed to people through the media. And so that conflicting information was a strong predictor of the early symptoms that people reported to us. Another very important predictor was the secondary stressors. As I mentioned, COVID brought upon us a cascade of events, and it wasn't just all COVID related stuff, but some of it was. So some people lost jobs, they lost wages, they needed childcare, they had poor access to healthcare at a time when they were dealing with a pandemic. So that secondary stress was a strong predictor of those early symptoms. Prior mental health and physical health, again, as I mentioned, we measured this was measured on our panel prior to the COVID pandemic starting. So mental health and physical health challenges that people had reported prior to the pandemic were associated with major increases in or higher levels of acute stress and depression symptoms in the aftermath of, in the early aftermath of the announcement of the pandemic, the early month of the pandemic. And then being young, and this is something that has been found in other studies as well. The younger people were, the more stress and distress they experienced. And I attribute some of that to the fact that a lot of people's lives got put on hold. And for young people, you have a much longer period of time that you're looking forward to in life. And then all of a sudden there's this challenge that's putting everything in life on hold. So I think that there was some, that sense that the future all of a sudden that you were looking forward to became uncertain may have contributed to some of that. So then we went on and we wanted to understand potential predictors of the wave 2 mental health outcomes for our sample. So we sought to understand what during this, over the summer during the pandemic, one of the things that was standing out was that there was a lot of debate in the country about whether the governmental policies to control the pandemic, the mask mandates, the social distancing rules, the stay-at-home orders, there was a big question about whether those orders, those policies were actually associated with the mental health problems that people were reporting. And so we looked at the University of Oxford Stringency Index. What they did was they collected data for across all of the states in the United States. And they looked at the actual policies and they created a database that we could then map onto, merge into our data set, because we had locations for where people lived. We could map the state restrictions that they were experiencing onto our at the time when the person had completed the survey. We could map that onto who our panelists were. So we mapped the stringency index. So the more stringent the policies, so the more intense so there were mask mandates and stay-at-home orders, the more stringent, the higher that score, the more stringent the rules were in your state, the lower the score, the less stringent they were. We also wanted to look at person-level indicators. So people were exposed to COVID. People knew people who had the disease. People knew people who had died. So we wanted to know, how did these personal exposures impact people's mental health at this time? And then we also, again, because secondary stressors were a major impact, had a major association with our early outcomes in the pandemic, we wanted to look at secondary stress. So we looked at the things like caring for a sick relative, lack of healthcare or COVID testing access, the threat of evictions, because many people around the country were threatened with evictions or evicted during the pandemic. And then media exposure to pandemic-related news, of course, is something we were studying. And what did we find? Well, as you can see here, when we looked at these different predictors, we found that state-level cases were not at all associated. So the number of cases of COVID in your state were not at all associated with distress, loneliness, or traumatic stress. The state-level deaths were not associated with distress, loneliness, or traumatic stress. And we did not anticipate this, but the stringency index was not associated at all with the distress, loneliness, or traumatic stress that people were reporting. What we did find, however, was that personal cases, so if you knew people who had experienced COVID-19, was associated. So was knowing people who died from the pandemic. So if you knew people who died, you were more likely to experience higher distress, loneliness, and traumatic stress. And in terms of the impact of being diagnosed yourself was one of the strongest predictors of both distress, loneliness, and traumatic stress. And then, of course, as we usually find, the media was a very important predictor. In fact, interestingly, the most important, the strongest predictor of traumatic stress symptoms that people reported in our survey. So, and I just want to say, a lot of these traumatic stress symptoms, a lot of time, media is not considered a significant form of trauma in the DSM-5, but it's clear that media overexposure to the media can contribute to traumatic stress symptoms. And then, as I mentioned, one of the things we did in this study that we really wanted to look at was we looked at the frequency of receiving conflicting information in the media. And again, as I pointed out earlier, we see that the more conflicting information people experience, the higher their levels of acute stress in the wave 1. And in wave 2, the same thing happened. We see that here, traumatic stress symptoms rose steadily as people were exposed to more conflicting information in the media. So clearly, what you get in the media is important. So what does this mean? Overexposure to the news media can amplify distress over time. There can be downstream mental and physical health consequences of that overexposure, and it's important to pay attention to that. The conflicting political agendas and contradictory messages that the news media were sharing with us, those were especially stressful for people. And what are our recommendations? We need to get the media to convey information without sensationalism or disturbing images. Our research has clearly shown that the more sensationalistic and disturbing the images are in a media report, the worse off people are mentally. We've also seen that we also would recommend that the public would limit their repetitious exposure to media stories, select authoritative outlets that you can go to, and then limit the amount of time you go. Plan to go like twice a day or whatever you need to get the information you need, because, you know, it's important to be informed, but don't overexpose yourself. Don't get caught up in doom scrolling, what we call doom scrolling. And then the public should be very wary of the unverified reports on social media. Those unverified reports are part of what may have contributed to a lot of that conflicting information that people were reporting, and how that was associated, as I mentioned, with our distress. Other recommendations include encouraging healthcare providers to tell their patients to temper their media consumption. Media consumption, overdoing media consumption is not good for you. It's been established well over many studies that we've done, and now some others have done. It's not good for you to overdo it. And very importantly, during this pandemic, one of the hardest hit communities during the pandemic have been communities of color. Black, Latinx, and Indigenous communities have suffered very disproportionately from COVID-19. And all of that suffering has been compounded by the historical trauma, systemic racism, and persistent poverty allocation. And so because of that, we believe that it's very important to allocate additional resources to traditionally underserved communities, for especially communities of color. One of the examples of how this could be done would be to have mobile vaccine clinics that go out into the communities of color where people may be hesitant or maybe not able to get to a place where they can get a vaccine. So we need to go to these communities and provide the information and provide the resources needed to protect themselves. So in terms of broader lessons that we've learned, one of the things that's really important when you're dealing with these kinds of collective traumas, especially when there's so many of them, acknowledge that uncertainty is stressful. Anybody experiencing major uncertainty is likely to experience some form of anxiety, and that's an appropriate response to a very challenging situation. So it's important to normalize what people are experiencing. It's also important to recognize that given the pandemic and all of the changes that the pandemic has wrought over the course of the past year plus, we may not go back to January, what life was like on January 1st, 2020 anytime soon. I mean, some of life might get back to what we consider our normal, but some of it won't. We also want to point out that one of the things that is really critical, and it's just something that for nurses is really critical, to recognize the individual responses, the individuation of people. No two people are exactly the same. Even if you can put them all in the same bucket that you want to put them in because of how they look or what they do or how they identify, no two people in any bucket are going to be exactly the same. So there's wide variability in response to these kinds of stressors. And it's really important to recognize the humanity behind each individual that you're caring for and pay attention to that and expect that variability. It's also important to remember, as I mentioned, anxiety can be contagious and it's a normal response, but so is compassion. So responding to people with compassion is a really critical piece of what we can do to help support each other and provide the social fabric that's necessary for us to recover from this experience. So if we work together, we can save lives. We have a social responsibility to support each other, and we can do that with a lot of compassion and caring and individuation. And then, while not minimizing the distress people can feel right now or have felt over the course of the past year, human beings, and this country is remarkably resilient, and we have seen that resilience show up in a variety of ways in the country. And so it's important to remember the resilience and support people to be more resilient. And then we will get through this eventually, and recognizing the strengths and coping skills that we never had. We may have found new things that are important for us as individuals to cope. So recognizing that, I think, is a really important lesson we can draw from coping with the pandemic and all of the cascading traumas that it brought on. So, any questions?
Thank you so much, Alison, for that fantastic talk. Maybe you can stop sharing your screen.
Yep.
so we could see you. We only have a minute for a question. We do have one question. Thanks so much for your presentation. You mentioned young people in your talk. I'm curious, by young, how young did you mean? Children, adolescent, young adults? And again, we only have a minute.
Okay, I can make that very quick. Young in ours, it's not children or adolescents. This is a survey of adults, 18 to, I don't remember what the top age limit is. So it's young people between 18 and I believe the top age was 30. So it's young adults, you know, young, late teenagers and early college age students and up to about 30.
Well, Dr. Holman, I'd like to thank you so much for that fantastic talk. Really learned a lot, and I'm going to go ahead and introduce our next panel as it's time for that. So without further ado, I'd like to introduce you to our founding dean and distinguished Professor Adey Nyamathi. And she is going to be presenting on the topic of the impact of COVID restrictions on substance use and mental health of persons experiencing homelessness. So please welcome Dr. Adey Nyamathi, and really looking forward to your talk, Adey.
Thank you. And it's great to be with everybody who's out there virtually. I am going to share my screen. And please let me know if you could see it opened up. Can you see it and hear me?
Yes, yes.
Yeah, thank you. So I'm actually going to share with you information about two studies. One is we're in the middle of collecting data. And the second one is something that just got started that we're really excited about. But as you can see, this first study was funded several months ago. And it's composed of researchers who are from schools of nursing and biological sciences at UCI, as well as nursing and medicine at UCLA and Los Angeles County Health Department. And what we were really interested in looking at is something that is relatively unknown, that being what is the impact of COVID on the homeless population. And these are homeless adults for the most part. This is my home away from home. This is called Skid Row in Los Angeles. And you could see on the upper left our community health workers who are working with nurses to deliver care, information, counseling to individuals who are homeless and live in these areas, either in homeless shelters like the Union Rescue Mission, where there's over 1,000 beds available, or in tents. I mean, our staff actually walk the streets and have continued even during COVID. So the opportunity for this study was really focused on the homeless population because Skid Row, which is in Los Angeles, about a 50-block area between Main Street and San Pedro, is a critical epicenter for COVID. And while stay-at-home policies have been wonderful for the majority of our population in the US, not so much for the homeless, because they have critical services and facilities that they need, whether it's drug treatment or needle exchange or a homeless shelter. There are many things that they are just not able to get because of social isolation. So it's been a real difficult problem and actually leading to depression, anxiety because of this lack of services. And the fact is that the homeless population are very much impacted with many comorbidities, which makes them very much at risk for COVID. So they have not only tons of chronic diseases, hypertension, diabetes, they don't eat well. They are consumers, for many of them, of alcohol, of illegal drugs, smoking, and on top of that have issues in terms of respiratory diseases and poor access to care for many reasons. Although there are many clinics in the Skid Row area, sometimes just getting to them is a difficult because of perhaps using drugs or alcohol. And I've mentioned, inadequate resources such as restrooms, hand washing stations, although that has become a little bit more obvious over the last several months. So really what we wanted to do was to understand, how does COVID impact this population? For example, how has it impacted their substance use? Did they increase their use? Did they decrease their use? Just because they couldn't get out and get the drugs or the alcohol? Or has it affected them emotionally? How have they kept in touch with families? And the social isolation aspect has been absolutely critical. And so the aims of our study were to first form a community advisory board of individuals who are homeless adults, as well as social and health service providers, to ask these kind of questions and to develop a semi-structured interview guide that we could use with the persons that are experiencing homelessness, as well as the service providers. So in terms of aim 2, that's when we actually used our guide that we had refined from our CAB to actually interview 21 homeless individuals and also 10 providers. And then in aim 3, which we're, so right now we are currently analyzing the data from aim 2 of all of the interviews that we've done, qualitative component. And now we're doing a structured survey with 100 homeless individuals. 50 of them were self-reported diagnosed with COVID, and the other 50 were not. And then we are also drawing blood on this population to actually look at antibody titers, because this is important for many reasons. One is for those who believed that they were positive, versus those who never suspected that they had the disease or always tested negative. What did we actually find when we did the antibody test? And also, did use of substances, alcohol, drugs, affect their immunity? That was another important question. And so it was a mixed method design. It was actually funded within a NIH funded study where we're currently also doing a hepatitis C virus study. Great collaboration with Los Angeles County Department of Public Health. And our model has always been utilizing nurse-led community health workers, where nurses and community health workers, who are basically the population who live in Skid Row, that have come to a higher level of functioning, in the sense that they may have held a job, and they have at least high school education, become employees of our universities, both UCLA and UCI, to be part of this study. And to be included, as I mentioned, they were either COVID positive or not. They did have to self-report being homeless. We wanted to collect individuals who've had a history of substance use to at least tell us how things may have changed. And they also were 18 and older. And a number of different measures, as you can see, we are assessing. We have actually about 50 out of the 100 already that have had their surveys done. But we look at all kinds of demographic factors. We look at social distancing, social isolation, loneliness. We certainly look at substance use, drug use, and emotional distress and depression. And as I mentioned, we are also doing laboratory testing. Now, this has always been quite challenging for homeless individuals, even though a portion of them are injection drug users. They do not want anybody messing with their veins. So we've had to bring on someone that was actually recommended by Dr. Shin and our doctoral student, Valerie Pham, who is actually such an expert in drawing blood. We are just so grateful for that recommendation, because he is just amazing, and he's already collected blood on over a third of the group so far. In a summary of what we've done already, Our CAB had about 14 members of the community that we worked with to develop our semi-structured interview guide. There were a few that were homeless adults, 4 of them, healthcare providers, and other social service providers like substance use disorder providers, mental health, etc. So we refined our semi-structured interview guide that then helped us with the one-on-one interviews that we have subsequently done, and training of the staff, because the staff actually do the data collection and interviewing as well as our nurses. And so what we've learned from our CAB is that loneliness was one of the major problems that homeless adults experience, especially during quarantine, where they were in some respects isolated from others, and in other respects, they were aggregated with other individuals that were homeless and, for example, in a drug treatment program. And it was extremely challenging for them. And I'll talk a little more about this for the next section, but limited access to care, a lot of fatigue about COVID, and need for services that they just were not able to get. They talked about violence on the street and inability to actually, even though they were tested for COVID, oftentimes they were never given the results or couldn't go back and get the results. So, and then in terms of the interviews that we did, we collected data on 21 persons experiencing homelessness and 10 health and social service providers. And this is very interesting, just to elaborate a little bit more on what I was mentioning before. Individuals who are quarantined oftentimes were so upset about being in a close-knit area with other folks that were going through drug treatment withdrawals and having to deal with their own emotional issues, that it really escalated the emotions of depression and isolation and anxiety for the most part. And so it was really interesting. What they shared with us was after they were able to get out, they just doubled and tripled their substance use. I mean, it created oftentimes a much worsening situation. And then because of the fact that the dealers weren't able to access the drugs that they usually bring into Skid Row, they were bringing fentanyl. And so there were huge issues with overdose and information just about the different types of drugs that were being used, because the usual drugs were no longer available. So we're still in the middle of analyzing the data, but the findings are quite impressive in terms of the range that we've heard. And then in AIM-3, we are still doing the survey. As I mentioned, about 50 individuals have been surveyed. We are still collecting the blood. The analysis has not been done of the blood yet. It's been collected in batches by Dr. Masudi from Biological Sciences. Dr. Shin is a major player in this grant, as well as the other folks that I mentioned. So we're looking forward to seeing how the rest of this grant will pan out. And then very briefly, I'm just going to share with you that we just received funding from the Susan Samueli Integrative Health Institute. We are so excited to work with Darlene Lee, who's a doctor, a naturopathic doctor, and her area of expertise is biofeedback. And this is one of the first times that we're going to be able to use biofeedback in Skid Row among a homeless population. And again, the investigators are from Susan Samueli Integrative Health Institute, as well as from UCI and UCLA Schools of Nursing, Medicine, and Public Health. And so just very briefly, we also are now just establishing a CAB. Our first CAB meeting is at 5:30 today. So we're excited to get our community healthcare workers, and then subsequently our homeless adults, to really hear about what this intervention is going to be like, how feasible is it, how accessible is it. And we're basically going to randomize 50 individuals who are coming from the 100 that I just mentioned from the COVID study. 25 of the 50 will be randomized into a heart rate variability biofeedback intervention, and the other 25 will be a control group. And we're basically looking at the impact of this intervention on one, reduction of anxiety, stress, and depression at 8-week follow-up. Secondly, whether this program will result in greater increases in heart rate variability, which is a good thing. That's what we want to see. And also whether we'll see any decreases in drug use and alcohol use at 8-week follow-up. I'm not going to go into the physiology of biofeedback and heart rate variability, but it's a form of using the individual's responses to meditation or biofeedback itself and using that to relax them and to decrease stress. So that's basically what we're hoping to do. And we're going to move right into the intervention once we get our IRB approval. And the CAB is, as I mentioned, our very first endeavor that we're doing for this particular study. So I am going to leave it at that and see if there are any questions from the group. Thank you so much, and I'll stop sharing.
Thank you, Dean Nyamathi. That was a fantastic presentation on such an important topic. I think I've seen on the news and through studies that, that last year there was a huge spike in overdose among the homeless adults across the US. So I think it's really important to really understand how best we can support homeless adults in our communities. So I guess one question I had was, and I guess before I ask, I do want to remind the audience to please go ahead and place your questions to the Q&A box on the bottom right. The question that I wanted to pose was, I wonder if in the qualitative focus group discussions, whether kind of fear of spread within shelters, came up at all, because there have been pretty striking outbreaks in homeless shelters throughout the course of the pandemic, and also if there were any kind of discussions about Project Room Key and other such interventions whereby there's government support to place homeless individuals into motels and other types of housing.
Yes, Dr. Shin, that was exactly what happened. A lot of the floors in the Union Rescue Mission, for example, other shelters actually closed their doors. There were very select few areas where individuals who had been in the facility were quarantined. Once they were okay, they were tested negative, then they were allowed to just stay in there, but they weren't able to get out. And the individuals who were on the street, and particularly those who tested positive, as you mentioned, Project Room K was a very important public health strategy to place homeless adults in hotel rooms. And they had a number of different hotels where nurses, in fact, one of our doctoral students, your doctoral student, Dr. Shin, Alex Jones-Patton, who actually worked as a room key nurse who provided education and counseling and tried to be the support connection to people that were isolated in their rooms in the hotels. So it was a double-edged sword. Individuals who were, as I mentioned, they were clustered with other people, but really were just going berserk in terms of having to deal with each other's issues and not being able to really center themselves, or being isolated and not having people to talk to. So it was a combination, but Project Room Key was an important opportunity to provide services to the homeless population.
Thank you.
I had a question related to that, if I could. So was the ability for, what struck me was when you spoke about these poor people not being able to get the results of their tests. I mean, they're going to all the trouble of getting testing and helping out both themselves and the community, and then we can't even find a way to give them back their tests. Any thoughts on that? And did this initiative perhaps help that?
Well, there was a lot of reasons why people that were homeless did not get test results. There was a phone app, and I'm forgetting the name of it, but the individual could go onto their phone and type in a few things, and they could actually download the result of their test onto their phone. The problem is with homeless adults, they don't hold on to their phones. They lose it, they sell them, they do all kinds of things. So their ability to get their result on their phone oftentimes never happened. Or if we even tried to help them look on their phone and find their results, we couldn't often do it sometimes. There were also a lot of different services that were providing testing. So very varied groups. One was LA County Health Department was doing a lot of the testing. Then there was the fire department. So there were multiple different groups, and the poor individual may not remember where they got tested. So they often don't have the results, but of those that do, they tell us what they thought their test result was.
Thank you. So I guess another question that I had was, I think you had mentioned the biofeedback intervention, which sounds really promising. And I wonder if you can, for those in the audience who are not super familiar with what biofeedback is, and you touched on it a little bit, but I wonder if you can explain just in slightly greater detail what that intervention is and how it might overcome some of the challenges faced by the homeless population.
So, I'm actually just beginning to learn a lot of that myself, and I'm going to really get a grounding in it today because we are doing our CAP session, and Dr. Lee is going to be presenting that entire piece. But my understanding is with biofeedback, they are in the sessions. We're going to do a number of sessions with the 25 homeless individuals that get randomized into that group versus the 25 who are in a education control group. They're each going to get 8 sessions. And what we're going to do is we're going to train the nurses and community health workers to utilize video and also a machine to evaluate their respiration. And by having them to do deep belly breathing, this is going to allow the person to see how their heart rate variability is changing, and to use that visual to get them to continue to think about, taking these deep breaths, the sequence of how many deep breaths, and helping them to do it when they're by themselves. And then when we see them every week for 8 weeks, we're going to monitor, did they do their homework? And how is this reducing their stress levels? And while the follow-up is going to be at 8 weeks, we're going to try and do some kind of measurement every week that we also see them. So the goal is to get them to feel during the training with the nurse and community health worker how taking deep breaths is going to translate into reduced stress, reduce hopefully depression. It's been shown to do that, and we hope to reduce substance use, because we know even from the COVID studies that when they're anxious and when they're depressed, they go to drugs as their number one way of coping.
I had a follow-up to that really quick. So are you saying that they're using the technology to kind of make that link between, their breathing and what happens to their heart rate, but then they would not use the technology in the future?
Well, we won't, yeah, they won't have the technology every day with them. I mean, they live in tents, they live on the street, they don't necessarily have a home for the most part. Some of them have a bed in a shelter, not all of them. But we are going to get them to be familiar with how the feeling is once they see it and are doing it, and that they will continue to do it in between the visits, where we will again show them and keep repeating and reinforcing.
Wonderful, thank you. Thank you for that clarification. We are pretty much almost out of time, so I'm going to go ahead and thank you so much for sharing numerous studies with us. Really, so appreciate your participatory, engaged research. It's so important, I think, especially for these underserved populations that you work with. So thank you again. And I am going to go ahead and introduce our last but not least final speaker for the symposium. And this is our very own Assistant Clinical Health Sciences Professor Sarah Campbell. Dr. Campbell, as of a little bit ago, and she's going to be talking to us about MindStrong, a coping solution for the COVID pandemic stress experienced by nursing students. Welcome, Sarah, and really looking forward to hearing your talk.
Thank you so much, Miriam, and I'm going to go ahead and share my screen. So hopefully, can you see that okay?
Yes.
Yeah.
Okay, excellent. So thank you for letting me present today. We're going to take a little bit of a turn into a different type of project. So let me give you some background into this project. This really is an evidence-based implementation project. So really just the idea was a pilot study to implement an evidence-based intervention as a means to address the stress experienced by our pre-licensure nursing students. So I used really a model called the Stettler model to implement an EBP intervention. And so as you can see here, I've listed the steps of the Stettler model. And so I went through these phases to implement this intervention. And it really actually was my doctorate program project. And so it was my capstone project. So luckily the timing couldn't be any better. And I really have a passion for wellness, mental wellness, and the holistic approach to mental wellness for our students, especially. So the problem, really, let's dive into a little bit of the background. We know that university students are stressed, but studies have shown that nursing students are more stressed than students in areas of other study. High levels of stress can lead to burnout, depression, anxiety, and even suicidal thoughts in nursing students. We've also found that a systematic review was done on 27 studies that were conducted on nursing students, and that included 9,000 nursing students done by Tung, Ho, and Lam in 2018. And this indicated that 34% of students, nursing students, experienced depression, and the percentage of depression was even higher among younger students at 41%. The problem has also gotten worse. So with COVID pandemic, a large survey was conducted last year in Gen Z college students. And the top symptoms experienced were trouble concentrating, loneliness, unhappiness, and restlessness during the pandemic. And 60% of these students indicated that the pandemic is making planning for their future impossible. Couple this with the fact that nursing students are precepting and in areas where they're facing the COVID pandemic and learning from frontline providers, this stress was even higher. Access to mental health care is a barrier, and that's true on university campuses. Only 37% of adults with anxiety and 65% with depression really ever get care, and that was pre-pandemic. Out of 775 CCNE accredited nursing programs, there were 155 that were randomly chosen. And out of those 155 nursing programs, it was found that none of them regularly screened for burnout related symptoms. So none of them screened for depression, stress, anxiety, or burnout. And only 9% of them had formal resiliency training or curriculum to address those problems. Some downstream implications. So what does this mean for our nursing students and our nursing workforce? Really, for new graduate RNs, it's found that they're not prepared to enter the workforce. They don't have the coping skills or the ability to deal with the emotional stress that they face. And we find that they intend to leave the practice early, and they do. Within the first year or two of practice, we're seeing nurses leave. And this is increasing our nursing shortage. And it's been predicted that for California, and by 2030, we'll be the state with the largest deficit at a deficit of 45,000 nurses. And that was pre-pandemic. Many nurses are now retiring early due to the stress from the pandemic. So this may be even worse. Then the National Academy of Medicine's Action Collaborative was launched to address clinician well-being in 2017. And in 2019, they came up with the fact that in order to address clinician well-being, we have to start upstream. We have to employ resiliency training in programs of study. So for pharmaceutical students, nursing students, medical students, it has to be addressed during their training programs. We did an organizational assessment, and some of the things we've found is that our recent attrition has been attributed to anxiety and depression. Our faculty and staff time, we spend a lot of time addressing mental health concerns of our students, and there is a lack of formal screening and curriculum to address the problem. In March 2020 and beyond, all of a sudden we got hit with what a lot of nursing schools got hit with, and that was the pandemic started affecting our clinical placements. Our student stress went up, our faculty stress went up, COVID cases were rising, students and their families were getting COVID. There was a sense of urgency this past fall, really to address the problem as our clinical placements were dropping off and student stress was mounting. So a PICO question, my PICO question really was, in college or nursing students, how do CBT-based skill building, which is cognitive behavioral therapy-based skills building, compared to no CBT-based skills building, affect stress, anxiety, and depression? And a search was conducted in 4 databases, and I came up with 14 good, solid quantitative studies were included in my synthesis. These were the types of studies I had. So 2 systematic reviews of randomized controlled trials, 6 randomized controlled trials, 4 controlled clinical trials, and 2 pre-experimental intervention studies. So some really good, solid, top tier evidence collected. And out of that synthesis, a critical appraisal was done. And really the recommendation was that there was a strong body of evidence that supports the conclusion that CBT-based interventions help reduce stress, anxiety, and depression in both nursing students and general university students. So the EVP intervention that I chose was one called MindStrong. And MindStrong is a CBT-based intervention that's been identified in the literature and has been consistently efficacious in reducing not only stress, anxiety, and depression, but also increasing self-esteem, healthy lifestyle behaviors, and academic performance. This particular intervention has been studied in over 20 randomized controlled trials in children, teens, but also in the young adult population, specifically university students and even nursing students. It's very cost effective and it's scalable, so we can do this on large groups of students. The intervention itself, it's been manualized. So we gave students manuals, and there's a practice opportunity. We didn't call it homework. There's an opportunity to practice skills each week. It's deliverable online or in person. So it's been provided in Zoom across the nation. So we knew we could do this remotely. And that was one of the key factors in choosing this particular CBT-based program. These are a list of the sessions, and these sessions are given weekly. So this was definitely something that could fit within a quarter system. So it worked out very nicely. So the purpose became really to evaluate the implementation of the evidence-based intervention aimed to reduce stress, anxiety, and depression in pre-licensure nursing students by bolstering some coping skills through the delivery of a CBT-based program called MindStrong. So some implementation strategies, our IRB determined it was not considered human subjects research. Participation was voluntary. So we, got students to volunteer. We let them know that their privacy would be maintained. This would have no influence on their grades. This didn't have anything to do with their standing in the program. Their consent to participate was obtained via Qualtrics software, and they received no compensation or incentives to participate. They were also informed that the data would be collected anonymously, and that when data was displayed, it would be done so aggregately and anonymously, and that sessions would be conducted via a HIPAA-protected university Zoom account, so people couldn't just come into our Zoom sessions, and that all information really would be kept confidential. So what happened in the Zoom room stayed in the Zoom room. The participants that we recruited, we did this during the weeks 1 and 2 of the fall quarter, and we recruited 21 students. One ended up dropping out prior to implementation, but of the 20 students that remained, they all remained throughout the entire program. So we didn't have any attrition. It was delivered in 2 groups of 10. So we divided them up into a group for Tuesday night and a group for Friday morning. So they did it on 2 different, so smaller groups of 10. And these are the participant groups that we had. We had 5 undergraduate juniors, 8 undergraduate seniors, 1 MEPN first year student, and 6 second year MEPN students. The data collection was done with well-validated and reliable tools. So for stress, we used the perceived stress scale, for anxiety, the GAD-7, for depression, the PHQ-2. And then we did ask a couple of program evaluation questions just to get an idea of, has this worked well for us? How helpful was the program for you for building coping strategies? How likely would you be to recommend the program to a friend? And which lesson did you find most helpful? So data was collected. We did get both pre and post data sets from 18 out of 20 participants. And so we were able to analyze data from 18 participants. We used a paired t-test to analyze the data, and a significance level of p is less than or equal to 0.10 was used. We also calculated effect size. We recognize that you can get statistical significance, but you may not have an effect. And we really wanted to see, did we really have an effect on student stress and anxiety and depression? So we did this by using Cohen's D with cutoffs of 0.2, 0.5, and 0.8 for small, medium, and large effects. So the results. So after receiving MindStrong, participants reported lower stress, anxiety, and depressive symptoms, and the decreases in anxiety and depression did reach statistical significance. A large positive effect size was seen for anxiety. So if you take a look at the table here, the 2 asterisks indicate that there was a statistical significance reached in the decrease in anxiety and depression. And then the effect size was large for anxiety. So it did have a good effect on anxiety. But we wanted to look at a secondary aim. So we thought for those students who scored in the moderate to severe range for stress, anxiety, and for those who actually scored as screening positive for depression, did this have more of an effect on somebody who had more severe symptoms? So we pulled those numbers, and for those with elevated symptoms, we actually got a large effect size in the decrease for stress, anxiety, and depression. So if you look at the numbers here, we had 3 students who screened in the moderate to severe stress level, and 8 students in the moderate to severe anxiety, and 6 students who screened positive for depression. And all 3 of those groups had a large positive effect size when they're, with their decreases in scores, with the pre and the post data, according to the data. So this we thought was quite significant, not only with effect size, but also clinically. The program evaluation, so we did ask them how helpful was this, and 50% of them said it was helpful, 38% said very helpful, and 11% said somewhat helpful. How likely were they to recommend MindStrong to a friend? 73% said very likely, and 27% said likely. The most beneficial lesson identified was the self-esteem and positive thinking and self-talk. And then the second most beneficial lessons were tied between stress and coping, and then dealing with your emotions in healthy ways. Some lessons learned. There were some recruitment challenges. And one thing I want to say, I just want to go back to the data on some of this. One thing to mention is, during this fall quarter, this fall 2020, if you'll remember back, our cases in Orange County began to climb again, exponentially. We started to see those numbers, especially, into November, and we went on lockdown again. We were also in a political climate that was really intense. And so students were experiencing high levels of stress. We had a lot of students anecdotally that were talking about financial stress related to school and to not being able to work and even just feeling that stress from their preceptors. Again, these are students who a lot of them were in clinical, and so they were being exposed to frontline workers and lack of PPE and these types of things. And each week that they were going through their quarter, they were having clinical sites taken away. They were in both PEDS and OB, and those were the sites that were being denied to students. So each week it was like, okay, that site. So they were really anxious. So to even have a decrease in these scores, was pretty remarkable. So early recruitment, I think lessons learned, early recruitment prior to the start of the quarter, it was somewhat difficult to kind of get going with our recruitment. Once we did, we had a lot of people interested. I would say really trying to avoid clinical hours. So maybe do both cohorts after hours to avoid times during clinical shifts. I would avoid collecting post-intervention data during finals week. That's another thing. The post-intervention surveys went out during finals week. And again, we got lower scores of stress. So the fact that our scores didn't go up was pretty remarkable. Value on investment, I think, with programs and curriculum that is focused on really dealing with stress, anxiety, and depression, we could affect our attrition costs and costs associated with attrition, increase student well-being, satisfaction, and make a clinically significant difference in our students' lives. And I think also decrease that burden of time that faculty spending and staff are spending on counseling students for mental health concerns. Future plans, I'd love to see MindStrong offered regularly, incorporated maybe into a student wellness course. So perhaps we do it as an elective, or we offer it a couple times a year as a standalone, and people are able to just join and volunteer to come in. It doesn't have to be facilitated by an advanced practice nurse. I'm a nurse practitioner. It doesn't have to be facilitated by a faculty member. It's easy to get trained. It's a 4-hour training, and this could be delivered by upper division classmates or some of our FNP students. So this is something that could be peer-to-peer, and I think that would be really effective. Increased numbers of students in the School of Nursing, offer it that, scale it upwise and then go even bigger. Evaluation, I think screening all students for anxiety, stress, and depression, this is a trend that's starting to happen in nursing schools so that we can identify at-risk students and provide additional support. And then target those with maybe the highest scores, recommend MindStrong, encourage them to do MindStrong, and then also include some open-ended questions for qualitative feedback as we are doing post surveys and evaluating the program itself. So lastly, I would say just really we're seeing the incidence of stress, anxiety, and depression, and the effects of burnout are really increasing due to the trauma that's been experienced, not only by our nurses, but our nursing students because of the pandemic. But nursing students need coping skills prior to launching into their careers. And faculty must seek out innovative ways. We've been charged by the National Academy of Medicine to really look at our curriculum and develop strategies to address it head on. And MindStrong is not only feasible, but it's effective in reducing stress, anxiety, and depression. And we should really be looking at how do we lower and decrease adverse events in this high-risk population in our future working nursing workforce. So that is it for me. Thank you very much. And I want to acknowledge those that really supported this project, because I couldn't have done it without their support.
Thank you so much for just a fantastic presentation. And what a great way to end the afternoon with a really promising intervention. So that really could move us forward. And I think you did just a compelling job of presenting the case that this could be an intervention that should be scaled up. So with that in mind, I do want to remind the audience again that we do have time for some Q&A. So please feel free to put your comments or questions in the Q&A box on the bottom right. And the first question we have is from Dean Nyamathi, and she says, fabulous presentation. But how did the students feel, and was there some challenge regarding the time needed to learn and practice Mind Strong in the middle of a quarter?
That's a great question. One thing I will say, I got an email from one of the students. We started on the Friday group. I got an email from a student on Monday from the Friday group after we started. And she said just in that weekend, she already saw a difference in how she felt about her stress levels, because she had always been, and some of this is, again, we talked about trauma, past trauma, and she had a record. She had the committee in her head, and she had some non-truths that had been spoken by a family member. And she was able to identify that that was not a truth, that just because it came from a family member and it was something she had internalized, that it didn't mean it was true. And she was able to kind of recognize that negative self-talk and kind of turn it around. And it had already in that 3 days made a difference. And she had to tell me about it. I mean, she had to email on Monday and say, oh my gosh, this is already making a difference. And I just thought, wow, what an impact. And one of the things we also did to create a safe space was, being that 10 people is a large number for CBT, and really talking about how because each time we came back, we'd talk about, how was your homework? How did it go for you? Does anybody want to share? So sometimes we would break we did Zoom rooms. So we'd break them up into groups of 2 or 3. That way they had an ability to have a more intimate group to talk about some of the skills, to talk about some of the coping. We talked about ineffective coping skills that we use. Sometimes we overeat, sometimes we use substances, and sometimes talking about that in a group of 10 can be intimidating. So by recognizing that, I broke them up into Zoom rooms, and I let them talk in smaller groups. And I think that really helped. We got feedback that helped, because sharing with 2 or 3 people is a lot easier than sharing with 10. So that was another thing that we did. So, but in and of itself, the homework wasn't big homework. It was just small skills practice. So they felt like they could incorporate it.
That's fantastic.
Would it be okay if I asked a follow-up question to that?
Sure.
Really quick. So to tee on from what Sanghyuk just asked about the homework, and then you talking about the lessons learned, and then from your lit review that said only 9% of programs have something like this. What do we need to do to make this standard practice here in our school and at UCI for our students?
Right.
That was exactly my question.
Yeah, and that's one thing that I think I want to look at is, again, the training is 4 hours. This program has come out of one called COPE, which is creating opportunities for personal empowerment, but it was adapted for young adults and is now called Mind Strong. The training is done remotely. It's 4 hours. It's very easy to train. The training is free. The manuals, you don't have to buy them, but they're $20 a piece. And so it's very cost effective. So, my goal is what if we had a DNP student that took on this project and scaled it? What if we now took the pilot to a bigger, landing point? And so I'm in talks with another faculty member who happens to be in her DNP program. And we're talking about maybe, piggybacking onto this and scaling it, because it's possible. And again, I don't think it has to be faculty. We know it doesn't have to be faculty. Where it's being done across the nation, because this is being done in more than, it's being done in 40 some odd states. It's done by peer-to-peer, and that can be really effective, and almost create a safe space for students to talk. So let's do it.
I'm convinced. I think you make a very compelling case. So I think that's all the questions that we have. And so, Miriam, do you want to transition us to the next?
Yes. So you've got the dean, the associate dean in the room here. So we're obviously having a meeting with you fairly quickly after this symposium. Thank you so much for that wonderful presentation. I want to just very quickly thank all the presenters for all their wonderful work. Thank you to everybody who took the time to both put their research together to talk. Thank you to all the attendees. And I have the honor of bringing our founding dean, Adey Nyamathi, back to the platform for our finale. She'll give us some closing remarks, and then we will say goodbye to everybody, and hope everyone has a wonderful weekend. So Adey?
Yes, thank you, Dr. Bender. I want to first say how wonderful the facilitators for this conference were in imagining it and putting it together, and also doing such a beautiful job facilitating it. So Dr. Shin and Bender, thank you so much for all your work on this. And it's been amazing. And Kate, thank you for your support during this as well. I also want to second the gratitude to the presenters. I mean, so many of our faculty who are doing such beautiful work, whether it's qualitative, quantitative, physiologic, or emotional. The work is so critical, and the ability to reach into the community and to work with persons, whether it's a national representative sample or individuals who are homeless living in Skid Row, or students. The populations are just so important. And during such a critical time as COVID, this research, a lot of it, which is pilot work, has the ability to move forward and be wonderful large grants going out. And think about the opportunity. I just have to say, this last conversation about bringing this Mind Strong, not only for the students, but for our faculty and staff, I'm just so excited about. And we will be tapping on you, Dr. Campbell. So thank you so much for presenting this. So thank you to all of the attendees for being with us. The majority have continued to stay the entire time. I hope that you've learned from this as much as I have. And thank you for being part of our hearing the wonderful work that's being done in our school. Thank you.
Thank you again. And once again, this is recorded. It will be available. We will make it available to everybody. You will receive an email. Thank you so much to Kate for making this happen with maybe one glitch, and for keeping us all on time. I so much appreciate your work. Thank you so much. It was an honor co-moderating this with Dr. Shin. Have a wonderful weekend, and we hope to be doing something like this perhaps again sometime in the near future. Thank you, everybody. Bye-bye.